Good evening and good morning to our colleagues in the other side of the world, the Western world. And this is the third international webinar of the Glaucoma Society of India. And I request the President, Dr. S.S. Pandav, to please give the welcome address.
Thank you, Dr. Chandrima, for organizing this webinar. And it's my pleasure to invite you all to this webinar and welcome to this forum today. And I'm very happy to say, and all of you know, that we have a very eminent speaker this evening, and we are all looking forward to hear from him. Our speaker for this evening is Professor Robert Weinreb. Professor Weinreb is the chairman and distinguished professor of ophthalmology at the University of California, San Diego. He is the director of the Shelley Eye Institute and also director of the Hamilton Glaucoma Center. You all know Professor Weinreb, actually. He doesn't need any introduction. But Dr. Chandrima will be introducing him formally a little while later. We all have, look forward to publications from him, and we have been attending his lectures and his talks in different forums. Especially, he's very, kind of one of the pillars of the WGA, which is doing a fantastic job, and we all get a lot of information and knowledge from there. So, on behalf of Glaucoma Society of India, Professor Weinreb, I extend a very warm welcome to you, and also thank you for accepting our invitation and being with us this evening. And I'm sure we are all going to be benefited today with your wisdom and with your talk. Today evening, we also have Dr. Rajul Parekh. He will be also be speaking, and he will be, Dr. Parekh is an accredited ophthalmologist at the Christian Medical College of Vellore, and he is an invited member of the association of the advisory board of the World Glaucoma Association. He is director of Shriji Eye Clinic and Palak Glaucoma Center at Mumbai. Thank you and welcome, Dr. Parekh, for this meeting. And we have Dr. Pradeep Vyas, one of the panelists today. Dr. Vyas is a senior consultant at Center for Sight, Indore, and he has served Glaucoma Society India as a honorary secretary, and he's always very keen participant in all our academic programs and keeps guiding us from time to time. Dr. Shanta, welcome to this meeting and thank you for joining in. Dr. Shanta is Director, Department of Glaucoma at Shankara Nethralaya, Chennai, and she again has contributed to Glaucoma Society of India over the years, and again a very keen researcher and academician. Thank you for joining, Dr. Shanta. Dr. Devan Tully is with us this evening. He is a senior consultant in Delhi, keenly involved in glaucoma education and regularly contributes to Delhi Ophthalmology Society and, of course, Glaucoma Society of India. I also welcome Dr. Vinita Pathak Ray. She is a senior consultant at Center for Sight and adjunct professor at the University of Hyderabad in India. And she is also very keenly involved in academic programs through the Center for Sight, that is the eye focus. And I think she's very busy these days with her own programs. And thank you very much for sparing your time, Dr. Vinita, and to be with us this morning. And I also welcome Dr. Manavdeep Singh. He's professor at the Glaucoma Services of Dr. Ram Manohar Lohia Hospital in New Delhi. Again, one of the very well-known and very busy hospitals. And Dr. Manavdeep also has served Glaucoma Society of India as treasurer in the last term. And of course, we have Dr. Tutul Chakravarti with us this evening. Dr. Tutul is also again a member of the Glaucoma Society of India and has been contributing to the society for a number of years. Currently, she is a Fulbright Research Fellowship scholar at the Hamilton Glaucoma Center, Shelley Eye Institute, University of California, USA. I welcome all of you to this forum, and also I welcome all those people who will be joining us through the webcast and also through the social media, YouTube and the Facebook. I welcome all of you, and I'm sure you're going to have a great evening and great time learning about glaucoma today. With this short message, I request Dr. Chandrima to formally welcome our chief guest and introduce the topic and invite him for his lecture. Over to Chandrika.
Thank you, Dr. Pandav, sir. I'm just sharing my screen. Dr. Weinreb needs no introduction, but it is customary to do so. So, Dr. Robert N. Weinreb is the Distinguished Professor and Chair of Ophthalmology, Director, Shiley Eye Institute, Distinguished Professor, Bioengineering, Director, Hamilton Glaucoma Center, Maurice Gleich, MD, Chair of Glaucoma, University of California, San Diego. Dr. Weinreb received his medical degree from the Harvard Medical School. He has trained more than 150 postdoctoral fellows in glaucoma, including chairs and many others who hold distinguished academic positions in the United States and throughout the world. Dr. Weinreb was the past president of the American Glaucoma Society, the Association for Research in Vision and Ophthalmology, ARVO, laid the foundation of the American Glaucoma Society, the World Glaucoma Association, and the Latin American Glaucoma Society. With more than 70,000 citations, his age impact factor, 131, as of April 2021, is among the highest in the world for both glaucoma and ophthalmology. The recipient of countless awards and prizes, he also is ranked #1 for world glaucoma by Expertscape. In 2019, he chaired the World Glaucoma Consensus on Glaucoma Surgery and also was editor of the report Kugler Publications, November 2019. And last but not the least, glaucoma patients from throughout the world are referred to Dr. Weinreb for his medical and surgical expertise. With these words, I formally introduce and extend a very warm welcome to Dr. Weinreb. You can share your scheme, Dr. Weinreb, and go ahead with your talk.
Well, before beginning, first of all, let me thank Dr. Pandav and Dr. Paul for the invitation to join you this morning or this evening, as the case is for almost everyone except me. I learned just prior to the meeting that the Glaucoma Society of India is probably the largest glaucoma society in the world, whose members are glaucoma specialists with training or fellowships in glaucoma. And I congratulate you. And I know that many of you have participated in the World Glaucoma Association webinars that we've been hosting, and I hope you've enjoyed them. I hope you've learned something from them, and I always look forward to suggestions from you for topics and how we can do better. I'm going to talk today about personalizing glaucoma with 24-hour intraocular pressure. My interests are fairly diverse. They run from the front of the eye to the back of the eye. My major research interests have to do with the biology of glaucoma, particularly the biology of what regulates fluid in the eye, what damages the optic nerve in glaucoma, and glaucoma neuroprotection. But recently, there's been something that's, I think, is very exciting. I think it's going to transform the diagnosis and management of glaucoma. And that's the topic that we'll be talking about today. So let's move ahead with personalizing glaucoma for 24-hour intraocular pressure. I do consult for a number of companies, as well as receiving research support from them as well. So everyone on this webcast this evening knows that at the current time, intraocular pressure is the only treatable risk factor for glaucoma. It doesn't matter whether you're in India, the United States, Europe, we all agree that lowering intraocular pressure is beneficial for glaucoma. The great Swiss ophthalmologist Hans Goldmann, who developed the applanation tonometer that we use today, was the first to say that Goldmann applanation tonometry has many shortcomings. One of the largest shortcomings is that it provides just a snapshot. We get a single measurement of intraocular pressure in the clinic. However, intraocular pressure is a highly dynamic parameter. Today, we see a patient in our clinic. We measure intraocular pressure. We might choose to see the patient again in several weeks or several months. We get another intraocular pressure, and we see them again. We might change their therapy, and we get another measurement of intraocular pressure, and still another measurement of intraocular pressure. However, as intraocular pressure changes throughout the day, what happens if it just turns out that at the time that we measure their intraocular pressure in the office, it's actually at a higher value than it typically is, and that the real intraocular pressure is more often lower than what we're measuring in the office. And the converse, what happens if those measurements are actually a little lower than what's typically happening in the real world, and we're not detecting the higher measurements of intraocular pressure? Whether it's lower or whether it's higher, we're being misled about intraocular pressure, and we're probably being misled about the efficacy of our therapies. And of course, this can lead to shortcomings in the management of our patients with glaucoma. Intraocular pressure can change moment to moment. It can change over seconds, it could change over minutes, it changes over hours, and it changes over the day. A number of years ago, we established a sleep laboratory at the University of California, San Diego. And one of the first things that we learned was that in 2/3 of our patients, the highest intraocular pressures occurred at nighttime and not during the daytime, and not when we're measuring the pressure in the office. Think about that. 2/3 of the patients that we've studied, and we've studied now close to 2,000 patients, the highest intraocular pressure is at nighttime when measured in the habitual positions, which means sitting or standing during the day and supine at night. Doesn't matter whether you're healthy, whether you have ocular hypertension, or whether you have glaucoma. Moreover, intraocular pressure is not conserved from day to day. And what I mean by that is the intraocular pressure at specific times on a given day does not provide meaningful information regarding intraocular pressure at specific times on other days. So if you measure the intraocular pressure at 10 a.m., and then you measure it again at 10 a.m., there's no reason it should be the same from day to day. And then we're also learning about all these factors that influence intraocular pressure: stress, body position, head position, blinking, eye movements, eye rubbing, intake of liquids, caffeine, medications, seasons, hormonal cycles, tight neckties, goggles, pillows, blood pressure, playing certain types of musical instruments, yoga, and yes, even sex. Something else we're learning about intraocular pressure is the effect of medications and the differential effect that they can have. There's a group of patients that we looked at in our sleep laboratory, and you see a typical 24-hour intraocular pressure curve. Tends to go down during the day, and then as a patient assumes a supine position, it increases, and then upon awakening, it goes down again. Well, those same patients given a beta blocker to use for a month and measured again, we learned that the beta blockers, in this case it was timolol, intraocular pressure is very effective during the day in lowering intraocular pressure, but the beta blocker is hardly effective during the nighttime period. Now that's very interesting because beta blockers, in addition to lowering intraocular pressure during the day, they're also lowering blood pressure. And that means that the perfusion pressure, the difference between blood pressure and intraocular pressure, is lower during the nighttime. Perfusion pressure might be even a more powerful risk factor for glaucoma than intraocular pressure. Now, drugs are approved for use in treating glaucoma on their ability to lower intraocular pressure during the day. Let's look at a prostaglandin analog, in this case, latanoprost. In these same patients who use a prostaglandin analog for a month, they're brought back into the sleep laboratory. We learned that, as expected, they're very effective during the day, a little more effective than the beta blockers. But look at the difference at nighttime. Prostaglandin analogs are still effective at night, perhaps a little less effective than during the daytime. However, they're not lowering blood pressure. So they're actually increasing perfusion pressure. And this is one reason why prostaglandin analogs have been my first line of therapy for 25 years. Another interesting fact about intraocular pressure is we still don't know what parameters are the most meaningful. Peak intraocular pressure is the one used by most clinicians for decision making. There's some data to support that, but it's not compelling data. In many of the large studies that you're familiar with, multi-centered studies, mean intraocular pressure was used, so it's the most extensively characterized. It's not typically used in clinical practice because we don't have sufficient amount of information. And more recently, fluctuation of intraocular pressure, whether it's the difference between the highest and lowest pressures during the day, or the difference between the highest and lowest intraocular pressures over a period of time. However, there's conflicting data with many types and multiple ways to analyze this information. So one of the things that's most interesting to me is the possibility that a lot of glaucoma damage is occurring at nighttime, whether it's the untreated glaucoma patient or it's whether the treated patient, particularly with a beta blocker. Now, this should not be surprising because virtually all diseases have a rhythm throughout the day. For example, in the early morning, corticosteroids, heart rate and blood pressure typically increase. Myocardial infarction and strokes are most frequent and severe. And some of you probably have arthritis, and you know early in the morning is the worst time. In the afternoon, allergies are worse. Fevers are more frequent. And body temperature peaks. Alzheimer's typically is worse in the afternoon. In evening, asthma attacks can be more severe and highest blood pressure can occur. And then during the nocturnal period, we find that blood glucose is increasing, body temperature and heart rate are lowest, and eye pressure in most of our patients is highest. So is it possible that glaucoma damage is preferentially occurring during the nocturnal period? Well, I ask a question. Isn't it absurd to manage glaucoma with single measures of intraocular pressure? As intraocular pressure is changing moment to moment, hour to hour, day to day, week to week. And I'm going to show you some exciting new information about how it even changes with seasons. Well, over the past several years, there's been attempts that have increased to obtain measurements of intraocular pressure over the day, and not just single snapshots, but get multiple measurements. Some of you might be familiar with the Triggerfish contact lens sensor. This is a device that was actually marketed in Europe. It was FDA approved in the United States, although never marketed. It's a contact lens that has a strain gauge embedded with it and actually measures the change in corneal curvature that is a surrogate for intraocular pressure. It's measuring the intraocular volume and highly dependent on the biomechanical properties of the cornea. Here's a patient very early who we first placed it to determine what it was doing, and we saw how it varies with saccadic movements. As patient blinks, we saw that there was an increase, and we became convinced that it was measuring something relating to intraocular pressure. The first patients that we studied a number of years ago with Kaveh Mansouri, when he was a fellow with us, we found something that confirmed the sleep laboratory work that we had done for 20 years. That in most of the patients that we studied, we found that intraocular pressure was lowest during the day, and then upon sleeping, it tended to increase. It didn't matter whether you were healthy, you were a glaucoma suspect, or you had glaucoma. There's actually been a few hundred articles published on the subject, and it was surprising in some respects that it never became widely used. But I guess there are a number of reasons for that. We've learned quite a lot about glaucoma and intraocular pressure. For example, we've learned that with resistance training, intraocular pressure is increased. We've learned with exercise, whether it be walking, running, or cycling, it goes down. With alcohol consumption, it can go down. And something that you probably already know, at least my esteemed colleague Tanuj Datta has taught me so much about the effects of meditation. It can go down. And with yoga, it can go down. There are so many limitations, however, with this technology. First, it's really not estimating the absolute value of intraocular pressure. It provides measurements with arbitrary units and not millimeters of mercury. And then it could also vary depending on corneal biomechanics, including hysteresis and whether there's any changes in corneal clarity. Regardless, who would want to walk around looking like this? This is what's needed to use this device, because there's an antenna and it needs to transmit the information to a detector which needs to be located locally. A much more exciting approach, in my opinion, is continual measurement of 24-hour intraocular pressure. And this is a topic that I became very interested in as a resident and continued to work on the subject. And then, more than 10 years ago, got interested in developing a new technology to do so. Here's a technology that has been implemented by Implant Data. Implant Data is a German company. I'm one of the original founders of the company and have a financial interest. This was the original device. This is what you're looking at is a flexible device. The gold area here is an antenna, and this little device is something known as an application-specific integrated circuit. In more current terminology, this would be called a chip. Now, the device is flexible, and that means it can be folded, very much like our intraocular lenses. And the original concept was to place this device at the time of cataract surgery through the cataract wound right after the intraocular lens is placed in the capsular bag. This device is placed in the ciliary sulcus. Well, what's the basis of this device? This is the application-specific integrated circuit. It has a number of pressure sensors. It has temperature sensors. It has all kinds of really interesting technology for storing and transmitting the information to a detector device. Several years ago, the first of these were placed. This is an eye 4 days after combined cataract surgery with placement in the ciliary sulcus of the device known as the iMate. You don't believe me? Because look at that. That's a beautiful looking eye following cataract surgery. But look what happens with dilation. There it is. You can see this on postoperative day 7. With dilation, you can actually see the antenna. More recently, the device has been adapted, so not only can it be placed in the ciliary sulcus, but it can also be placed in the suprachoroidal space. This is a surgery performed by Kaveh Mansouri, who I mentioned earlier. Kaveh is based in Lausanne, Switzerland. And he performs viscocanilostomy, viscosclerectomies, viscosclerotomies. This is Kaveh's surgery. He's an excellent surgeon. He's taken down the conjunctiva. He's created a scleral flap. And now he's dissected another flap underneath. And here he's unroofing Schlemm's canal. He's cutting out the second flap. Placing the incision in a very thin scleral bed, injecting viscoelastic into the suprachoroidal space. And here's the iMate device. And in that space that he created with the viscoelastic in the suprachoroidal space, he's very gently inserting it. It's actually quite an easy insertion. It's placed in the eye. It has the same ASIC, or application-specific integrated circuit, and then basically sutures the flap, closes the conjunctiva, and the intraocular pressure measurements are acquired. Well, how are they acquired? Typically, they're acquired whenever you bring a detector close. So you might say, well, is there a battery? What happens if the battery no longer has power? Well, there is no battery. It uses something known as inductive power. Inductive power means if you bring an electromagnetic current or source of energy close, you'll induce a current in the device, and that will power the device, and it will transmit the information to the detector. So here you can see a detector. However, the detector, we've also placed them in spectacles. You wear spectacles, and right there you can obtain measurements. We've had them in pillows, so when somebody is sleeping, the information is being detected. And where does the information go? Well, it can go to the detector. It can also be sent to a device, such as an iPad. It can go to an iPhone. It can go to the ophthalmologist's office. It can go and remind the patient that the pressure is high, and perhaps they should be taking their medication that they forgot to take. So not only will it help the physician, but it helps the patient with adherence as well. Well, what does this mean for glaucoma management? Well, here's one of the early sets of data from a patient. Instead of a snapshot, you can see that over a period of months, we obtained over 1,500 measurements. And actually, we could obtain many, many more measurements. And some of the things that you can see is how intraocular pressure changes over time, and even within the same day, how you have tremendous variability of intraocular pressure. The device was studied. This is a study in 22 primary open-angle glaucoma patients done in Germany. And you can see, again, very safely performed. This information was published in 2020 in the American Journal of Ophthalmology. And with those same patients, we've been able to do some very interesting work. And this is a big shout out to the brilliant Harsha Rao in India. Harsha has been instrumental for helping us understand the meaning of this data. As you know, Harsha was a fellow and then obtained a PhD, and he's simply incredible in handling data and analyzing data. And a lot of the work that we do could not be done without Harsha. So this is a group of the same 22 patients, and in this case, we obtained over 100,000 pressure readings from the database. And a very interesting result, and this was published in the British Journal of Ophthalmology last year. What we saw is the seasonal variation of intraocular pressure. Again, these are patients in Germany where the winters are cold and the summers are warm, and intraocular pressure was lower during the summer months. I wonder what would happen in India, where it's always warm. Here's another study where we looked at the influence of eye movements. This is in press, or maybe perhaps has just recently been published in Investigative Ophthalmology and Visual Sciences. we had the patients in whom the device was implanted, and we had them look in different cardinal positions, to the side and up and down. And here's what we obtained. Interestingly, anytime you're looking up, the intraocular pressure is increased. This is particularly interesting since we know with thyroid eye disease, where the muscles are restricted, we can test for the effects of muscle restriction by having patients look up. And typically the pressure goes up very, very high. In other directions, intraocular pressure was lowest, particularly when looking to the sides. But in looking down, intraocular pressure does not go up like it does when looking up. Here's another study looking at the effects of body position on intraocular pressure, body position. And here you can see that the highest intraocular pressure is for patients when the dependent eye, which means the lower positioned eye, and in fact, the lowest intraocular pressures are in typical sitting or standing positions. So patients who are sleeping, the dependent eye, if they're on their side, the intraocular pressure is going to be very, very much increased. Another interesting study, this is the intraocular pressure of a subject according to body position, and pattern ERGs were obtained. And again, here you can see the difference between the lateral decubitus and sitting positions. Of course, in the lateral decubitus position, the dependent eye, the intraocular pressure is highest. But look what happens to the pattern ERG. The dependent eye, where the pressure is highest, you can see that the amplitude of the ERG is actually lower. Will this be useful for testing perhaps a stress test for glaucoma? Now, I mentioned some exciting new news, and this is very recent. The device has had the European CE mark for a number of years, for the foldable device. And just about 2 weeks ago, the FDA, the Food and Drug Administration, the regulatory agency in the United States, has given us what's termed breakthrough designation for the suprachoroidal device. And that means that they're accelerating the approval process and working with implant data to bring this into clinical trials and bring it into clinical practice in the United States. So what does it all mean? Well, 24-hour intraocular pressure monitoring offers potential for personalizing intraocular pressure for optimal glaucoma measurement. And I believe that this means that the paradigm change is here. This is something that I've looked forward to since I was a resident. And I was a resident a long time ago. Routine clinical intraocular pressure monitoring will improve management. We have a whole group of sustained release treatments now, including in the United States we have Durista, which is an implantable bimatoprost, but we don't know when it go out of control. But if you can measure over 24 hours the intraocular pressure from day to day, the patient will recognize when it's time to go into their doctor and be treated again. It'll also improve adherence to medication. And of course, for me, there's a plethora of data which will provide even greater, deeper insight into glaucoma. There are challenges with these technologies. Long-term safety. We want to reduce the size to make the application of it even easier. What are we going to do with the data? We're getting millions of pieces of data. How are we going to interpret it? And we have some deep learning strategies to do that. But I think that we'll need to reevaluate our practice patterns. And of course, who's going to pay for all of this? John Liu, Professor Emeritus now at UCSD, I recruited him from Harvard in 1991 to work with me to develop a sleep lab. John was working on mice at the time, and I brought him to UCSD, and I said, John, I love your work, but we're going to do it in humans. And he looked at me like I was crazy. Kaveh Mansouri, who worked with me as a fellow a number of years ago, has just simply been extraordinary in organizing a lot of the clinical trials. And then I already mentioned the brilliance of Harsha Rao. So with that, I bring greetings from the Hamilton Glaucoma Center, the Shiley Eye Institute, the University of California, San Diego. We live on the edge of the Pacific Ocean in the lower portion of our country. Good evening to everybody, and I look forward to any discussion that we might have. Thank you very much.
Thank you very much, Dr. Van Reb. That was indeed a very interesting, informative, and educative talk. And we look forward to your inputs into the questions that we have following the next talk. So we'll move on to the next talk, and then we'll come back to the questions and have your inputs and have our panelists along with you on the discussion. So I invite Dr. Rajul Parikh to please share your screen and start your talk.
Good evening, Dr. Chandrima. And after the fantastic talk of Professor Van Reb, I will talk about teleglaucoma. I have been asked to talk about 15 minutes. I'll try to finish my talk before that. So basically, I will concentrate that what is the future of teleglaucoma telemedicine in the real world, especially from the Indian scenario. Now, the teleglaucoma research has been going on for a long time. Since last year, with the start of the pandemic, the things really took the upturn, and the research and teleglaucoma things has really speed up. So I will try to concentrate that what is telemedicine, what are the challenges, what technology we have, what we did in last 1 year, and what we'll continue doing, or what we can do in next year or two till the COVID pandemic is will continue, because I don't think it is going to go near so fast. And what is the future of teleglaucoma? Purely from the glaucoma management perspective. Now, if you look at the definition, telemedicine means the use of medical information shared from one side to another using electronic communication to improve patients' clinical health status. So basically, it is not a specific service, but it's a collection of means to enhance the care and education delivery. And so there are different perspectives. There can be a different scenario. The CCHP has defined there are 4 different categories. The one is live video conferencing, which is also called synchronous video. So we talk to the patients directly, or different healthcare people. They understand the problem. We can advise some investigation or immediate consultation. The other is asynchronous. That means the recording has been done, and the expert, the glaucoma specialist or the ophthalmologist sees when they have a time, and they provide the input to the primary healthcare level, and the primary person, the technician, takes care of the the further part, the actions, whatever is required. The third, remote patient monitoring, and Professor Van Reb was just talking about that approval FDA has given for the IOP measurement. So remote patient monitoring is something of future, and there are lots of options available. So we collect the personal health, the glaucoma data, whatever, at one location, and it's transferred electronic to the glaucoma experts or physician at other level, and based on that we take care of the patients. The patient doesn't have to travel to the far centers for the management. And the fourth is the mobile health. This is another area where there is a huge potential in future. As far as now telemedicine for glaucoma is concerned, we have three different categories. One, screening. Second, glaucoma diagnosis. And third, long-term glaucoma monitoring, follow-up. Now, what data we have, let's look back the data, whatever is published in last few years. So if you look first, before we start, all over the world, one thing is very clear, that open angle glaucoma has never been labeled that it requires screening. So I'm not going to talk that screening is must for glaucoma, that we know. There are lots of limitation, and there is not enough evidence that screening really helps. But the data what we have, it says that systematic review of teleglaucoma screening showed that sensitivity was 83%, specificity was 80%, 79%, so inadequate. For the ideal screening test, the sensitivity should be at least more than 80% and specificity should be more than 95% to reduce the false positive going to the clinic. So the teleglaucoma at this point in time does not come in that category that we can use for the screening. So there is definitely lots of potential for that. For diagnostic, the data published by Verma et al. Showed that the 70% of teleglaucoma patients referred for suspected glaucoma, it could be managed by the referring primary healthcare provider and did not require in-person evaluation by specialists. So to a certain extent, some patients can be managed by diagnosed also by the primary healthcare persons. Of course, it requires training, which is a different aspect, which I'm not going to talk about it. And third is, this paper was published in 2007 in I, where they had a proper system in the place, where technician evaluate the patient. Then you have a pre-test questionnaires, visual acuity, visual field, anti-segment OCT, IOP, after dilation disc photograph, corneal thickness and imaging. And based on that, the technician will train to either refer the patient to the glaucoma expert or send back the patient home. Now the data what it shows that nearly 85% of the patients which were referred to the expert, they really required, they all had some amount of glaucoma monitoring required, some required treatment also. So it was good that more than 85% patients were sent to the clinic for management. They really required management. Now to do for the false negative aspect, the 10% of the patient, nearly 10%, who were labeled not required any evaluation by expert, were sent to the expert for the evaluation to look out false positive. And what they found that nearly 20% of these patients did require some amount of monitoring. Not very few patients require treatment. So from that perspective, the technician labeling not required immediate treatment was not wrong, but they did have ocular hypertension or some amount of glaucoma suspect and required some monitoring which were missed. So the negative predictive value was 84%, not very high, not great, but again with the more proper teaching, this kind of system can be placed and can be diagnosed glaucoma in a peripheral centers. And the third was the glaucoma management follow-up aspect. Before that, since India is a huge angle closure suspect, PACD, primary angle closure glaucoma, we need to know how can we do screening or peripheral evaluations by remote control. Can we do anything about it? The Ronnie and Nikhil had published this data where the technician were trained to look the von Herrick and the antechamber depth and its impact on the diagnosis of glaucoma, angle closure glaucoma. And what they found that simultaneous or sequential, the positive predictive value of these two tests combined was 86%. Again, not good enough to use as a screening tool, not good enough to use for the diagnostic either. And subsequently, the Cochrane database recently published that various non-contact tests used for the PACD, all tests individually did not have high sensitivity or specificity to be used for the screening or diagnostic method. So what they concluded that these tests have potential, but at this point in time the data is not sufficient enough. They also noted down that the high quality studies required, because whatever the publications are there, most of them did not meet the criteria required. So the high quality studies required to evaluate the performance of these tests and how to use them in a day-to-day real world for the screening or for the diagnosis, basically peripheral tele-screening sort of thing, or tele-diagnosis of glaucoma. The third aspect was long-term glaucoma monitoring. Once we diagnose the patient, because at this point in time, we call the patients every few months for measurement of IOP, for perimetry, for imaging. So can we manage on the peripheral centers, and the data only comes to the glaucoma expert on a virtual way. So the publication, this was done again a couple of years back, where 3 glaucoma experts were given the same set of data and were asked to do a CAPA agreement. The CAPA agreement show 0.3 to 0.4, which is a fair agreement, not the great agreement. The ideally it should be more than 0.6. So it can be used. The peripheral centers can do the investigation, and the expert can evaluate and give opinion. But the CAPA was just average enough, not great. So we need to work on this strategy also, for if we really want to convert the glaucoma practice into the clinic glaucoma for management perspective. Now, if you look at the guideline, basically it doesn't require guideline. We know what we require. We require visual acuity, we require IOP, we require perimetry, a Goldman standard white and white perimetry. We required imaging. In an angle closure glaucoma like Indian scenario or Eastern Asia scenario, we required gonioscopy, we required disc photograph, imaging, and of course slit lamp emulation. These are the things we required. What we have. So if you look at the CAMGIS data, this is a comparison of remote operating slit lamp microscope, and they published the data comparing with the slit lamp, real slit lamp in the post glaucoma patients, surgery patients, and they found that the CAPA was 0.9. I mean, 0.9 is perfect. So the remote slit lamp examination picked up all the finding which is required. In fact, it also picked up the lab leak. So this is the one aspect, the remote slit lamp. Then if you look the Derek's publication, that he has actually shown the model of the robotic remote control stereo slit lamp. So we have this kind of thing is research which can be used. Most probably it will come in the real practice in future. So these are the things we have to look into it. Then we can have a teleophthalmic. So we have, if the institute has lots of peripheral centers where the slit lamp either in the real time or the photograph can send to the experts, and they evaluate and give their opinion and send back the reports to the technician which take care of the patient. So we can also train the technician to look into the peripheral interchamber depth, how to take photograph. We can train optometrists to do gonioscopy, which can take care of angle closures issue from the Indian scenario. Now the teleophthalmic setup is a cost and it's involving. So the other option is that we can have a portable slit lamp adapters rather than the proper telemedicine, where they can take the photograph and send the photograph to the main clinics, and the ophthalmologists give the evaluation. Of course, this cannot replace the glaucoma management what we are doing now, but it can help us, especially in the scenario like COVID. Now, the whole things, as I mentioned, that since the beginning of the last year, the starting of the pandemic, changed our management style, made us think in a different way. And that time, lots of guidelines had come. The UK guidelines say that we can divide the patient into 3 groups: low risk, where we can do a teleconsultation. We can ask patient to stay at home and come back only when required. Where high risk group, where patient required surgery or pediatric glaucoma or uncontrolled pressure, they required immediate checkup. And medium risk, that we can do some of the teleconsultation and we can call for the IOP on a little longer period. Rather than 3 months, we can delay it by 6 months. We can intermittently do a teleconsultation, look for the side effect, look for the adherence. So this kind of guideline. So as most of us were not doing teleophthalmology, we also didn't have any system in place till the COVID began. We had EMR, it was cloud-based, so we could assess from the home, but there was no system. So we set up a system and we tried the patient that only necessary patient should come to the clinic. So and intermittently we were doing teleconsultation. We were looking at data, and we were asking them to take, if they have any issue, send their photographs to us and look the photograph, and if we can at least identify the side effect and guide them. So I'll just give few examples. Like at the same time, I did some search and I found out that there is a website where the patient can assess their visual acuity sitting at home on their laptop. So we asked patient to do that. We photograph old records. If we didn't have, the patient was new, then we asked them to send the photographs to the WhatsApp or email and look the old perimetry and imaging and help them out. So like this one patient was operated a couple of years back. He had hypotonic, so we asked the patient to look visual acuity at least and come only if it was necessary. The patient was stable on visual acuity, so at least we were sure that it's not deteriorating. We could definitely help the patient with subcon hemorrhage and this kind of thing and reassure them that definitely they do not require any ophthalmic checkup. We could also, the patient complaining of the side effect, like this patient had Brimodine and alpha-2 allergy, we could guide the patient that stop alpha-2 agonist, change the medicine and only come back after 1 month, 4 to 6 weeks with the new medication. So we could avoid one visit and check the pressure with the new medications. Like this one patient called up saying that sudden blurring of vision, and the photograph looked very, classic of acute angle closure. We asked the patient to come immediately and we could save the eye with the immediate management. So these are the things we could do during the COVID time and definitely can do in future also till the pandemic persists. Now what is future? So the ideal future is, as I mentioned, that vision at home. We have the website, we can modify that. As Professor Weinreb is going into detail about the IOP measurement, the 24 hours IOP measurement, I am not going to go in detail. Various sensors along with the IOL in the suprachoroidal space. But the only problem with the sensor at this point in time, that it requires intraocular surgery and device implantation, where most of the glaucoma patient may not have the surgery, or they may have operated for the cataract a long time back. So we need to work out those things. But once that thing is in place, we can measure IOP at home only. They don't have to come back. We may have a remote slit lamp app on the mobile where we can examine this on slit lamp. The perimetry, this is the internet-based perimetry, but this is a screening tool. But we have a virtual perimeter. The PAM scan has a threshold program, but they do not have the progression software. So we need to work, we do have a research with the progression software where the patient can do perimetry with the virtual perimeter at home only. Then we have lots of handheld OCT. This is one developed by Duke, this is developed again by Nodal Vision, a different system where the technician can go home and patient can perform OCT at home only. So everything is done at home. The data is sent to the glaucoma expert. We see the data and advise the patient that what they need to do, whether they need any examination or whether they can just continue with the medications. Of course, the artificial intelligence, another new things. We need to wait for the data, but it will help us in teleglaucoma in a big way. The other aspect is that because the telemedicine, as I said, that the peripheral center, developing peripheral centers is a very time-consuming and very costly affair. The small centers can develop a tie-up with the various peripheral centers with a different type of equipment. So if I have a tie-up with different ophthalmologists who can measure IOP, they are not glaucoma specialists, they do IOP measurements, slit lamp, and send data to glaucoma experts like me. So it would be a time saving as well as financially feasible object. So this is collaborative telemedicine is another a future as far as the glaucoma is concerned. To summarize, we have telemedicine is definitely challenging. At this point in time is in early phase, definitely not a viable option to stop seeing glaucoma patients in OPD. But during COVID time, we can manage certain patients. But of course, in the long run, we have to have lots of another infrastructure development to really go into the teleglaucoma management. But tailored approach, till the COVID is going on, we can have, of course, a different technology used like the video consultation, intermittent visits. For screening, as I said, that angle closure, we don't have much data. We need to do lots of improvement At the same time, when we rely on the technician, we have to have a proper training to the technician, because that would directly lead to a proper diagnosis or incorrect diagnosis. So those things we have to look into it. But teleglaucoma has a bright future. We need to have some data, but for time we can use intermittently in a modified way, not proper teleglaucoma, but a modified person-to-person experience. Thank you.
Thank you very much, Dr. Rajul, for that very detailed layout of the perspectives of teleglaucoma in this COVID times. We shall come back with this at the end of the panel discussion. So we move on to our experts this evening. We start with our president, Dr. Pandav, and then we have questions also coming in from the audience. So, Dr. Pandav.
Thank you, Chandrima. I think we had two great talks this evening. Both of them were really informative, and regarding the continuous monitoring of intraocular pressure, and also how to help these patients while they are at home. So I think both are really important in today's world. We kind of have known that the IOP is a very dynamic thing, and we kind of knew that it varies from time to time, and there are whatever we are recording in the clinics is not really, it's just a snapshot, is a very small thing, but the overall what's happening. And also we knew that IOP fluctuations somehow would be important. But I think till now we didn't have any tools actually to put this information, this knowledge, to practice. An average glaucoma wouldn't be benefited even if we knew that something of that kind is happening. But I think what Professor Weiner has told us today is that now we look forward to having technology and having techniques where the benefit of this knowledge could actually be transferred to the people who really need it, and that I think is a very great innovation. Then absolutely, I think we should be looking forward to. Of course, this kind of a new technology, and there would be some limitations in the beginning, but I think over a period of time, the things would certainly get better. I think the one of the questions that came to my mind was, Professor Weiner, because you said these devices, they don't actually have batteries or anything. So, and they can generate data continuously, but they don't store the data, because they don't have anything to store the data inside, or do they store data inside? And that would mean that if you want to have a 24 hours IOP data available, so the patient has to have, recording device very close to his eye or, somewhere in the body, which could power the, implant as well as get the data back to, is that how it works at this point of time?
Yeah, so, the current device has very limited storage capacity, but of course, given the very rapid advance that we've seen in some of the chip technology, all the future generations will be storing it. The only reason that we designed it this way was in order to be able to power it. But to store, a day or a month or even a year's worth of data is actually quite trivial. The other thing I want to emphasize is, the ability to miniaturize these. Let me congratulate Raju Parikh on his, what I thought was a very thoughtful, erudite, and evidence-based lecture. Just terrific. As he pointed out, at the current time, these devices are placed at the time of glaucoma surgery. But in the near future, these devices will be miniaturized, and I think that we'll be placing them in the clinic. We'll be injecting them. We have a device that we've developed at the university right now that's an optical measurement of intraocular pressure, and these things can be placed in a needle and placed within the anterior chamber. And I think that's where we'll be in, in 10 years, that to be widely adapted in all glaucoma patients. As he pointed out, we don't want to be able to have to do these things with surgery, but something that we can do very simply and safely, in the clinic.
So, I think that's great, because if these devices can be implanted in the clinic, so that would actually be wonderful. The other things that come to my mind is that now once we know that we have a almost continuous recording of IOP using these technologies, now how do you think we would be do you think on the therapeutic side also we are equally prepared to deal with that kind of a data? So now I know the data is coming second by second for a patient how the IOP is going. But on the therapeutic time, do you see we'll have limitations and have to do what we are required to do once we have all that information?
So yeah, that's a great question. First I think we'll enhance adherence. Secondly, we'll be able to treat pressure spikes. When does glaucoma damage occur? Is it occurring continuously or continually throughout the day, or is it only occurring at certain times of the day? And is it occurring at times when intraocular pressure is increased? Imagine being able to recognize when intraocular pressure is increased and then being able to place an eye drop or do something that can lower the intraocular pressure. That's where I think we'll be going here. I think it'll, and I think we'll also have devices that will integrate pressure sensors with the devices. For example, imagine a glaucoma drainage device that has an integrated pressure sensor, and imagine being able to detect the increase in intraocular pressure and then regulate the outflow through the drainage device. So it continually is adjusting the intraocular pressure and is not dependent on the patient taking an eye drop or even a medication.
That's great. I think we are looking forward to have a very exciting technologies in the coming days, and good for our patients. Any questions or any comments from the panelists? I think with that I'll kind of open this discussion to. Chandrama, you are muted, I think.
Very sorry. On that note, while we are talking about therapy, there's a question for Dr. Van Reb. You mentioned that beta blockers and prostaglandin analogs lower intraocular pressure, and you have been using prostaglandin analogs for a long time now as first line of therapy. How would you rate netarsudil and ripasudil, which are new in the market today, in lowering intraocular pressure?
Yeah, so I mentioned that my first line of therapy is the prostaglandin analogs. And I've stayed away from beta blockers because I'm concerned that they lower perfusion pressure at nighttime. Again, beta blockers are effective during the day. They don't lower intraocular pressure at night, but they do lower blood pressure. Netarsudil these are very interesting drugs, the urokinase inhibitors. They're extremely effective in lowering intraocular pressure. They have novel mechanisms of action. And I think what limits their use in clinical practice is some of the ocular side effects, the hyperemia and the corneal changes that are associated with them. But again, extremely effective in lowering intraocular pressure, additive to other antihypertensive drugs, and perhaps they also have some salutary effects on the optic nerve.
Professor Weiner, I think while talking about this perfusion pressure and IOP, I think, like you said, the perfusion pressure is important, and that would, the IOP would modify that. So lowering IOP helps. But what exactly is actually the relationship, between this systemic hypertension, systolic high blood pressure, or diastolic high blood pressure, and IOP and perfusion pressure? I mean, is there a kind of straightforward relationship there, or is kind of a very complex thing?
Oh, it's very confusing. I don't know if it's complex as much as it is confusing, because the data that have been acquired in the studies that have been performed are typically based on snapshot measures. They obtain snapshot measures of intraocular pressure. They obtain snapshot measures of blood pressure. And, the current thinking is if the blood pressure is too high or if the blood pressure is too low, it's not good. Is this correct? It very well could be. But I'm looking forward to a number of studies that will be done where we get 24-hour measurements of both blood pressure and intraocular pressure, and we can reassess the relationship. One thing is very clear. There's a group of patients that have very low blood pressure at nighttime, particularly diastolic blood pressure. And those patients seem to rapidly progress. Now, identifying those patients is one thing, but what do you do about that? You can adjust maybe their antihypertensive blood pressure medications, if they're on them, so that they're not getting their maximum effect at nighttime. But we don't have much evidence that raising the diastolic blood pressure during the evening is going to do anything for the progression of glaucoma. I think we need to apply some of these new technologies. And there's some very exciting technologies. Again, referring back to the excellent talk given by Raju Parikh. Raju, I don't know if you know, but there's technologies now that have not yet been brought into the public eye, but they're still under development, that will perform an entire eye exam, including eye movements, intraocular pressure, OCT, photography, and visual fields in 10 minutes. Basically, you put your chin in a headrest, and 10 minutes later, everything is done automatically for both eyes. And that will have a tremendous impact, on teleophthalmology. Tremendous impact on teleophthalmology. The other thing that I think is going to affect it is some of the work with deep learning. We've published now several manuscripts with results that are astounding to me. I thought that photography of the optic disc was an old technology. We've continued to do them in my clinic, and in Europe it was abandoned many years ago. But now, our group and others have been able to take those photographs and we're able to not only detect glaucoma with deep learning strategies with better sensitivity and specificity than we're doing with OCT, but also we're able to predict which of the patients are likely to progress. And so screening devices in the future, might simply be a very inexpensive camera to take an optic disc photo. And also under development are very inexpensive OCTs. So not only will we have home visual field testing, which we already have, we have a number of patients now that are performing home visual field testing with virtual reality goggles, but we're also going to have home testing with very inexpensive OCT devices. So you wonder, with all this going on, what's going to be the role for the ophthalmologist? I wonder about that. Are we going to have to look for another job?
You'll be redundant, Professor Weinreb.
I hope not. because all of this is going to go into, all the data will be collected. And of course, there'll be algorithmic approaches to treatment. Mm-hmm. So what will be our role? Well, I don't think that time is near. I think those of you who are practicing, I think you'll have at least another 10 years or more to be able to help our patients. But in the future, I think a lot of this is going to be automated in a very similar fashion to what we heard from Raju Parikh.
Oh, well, Professor Weinreb, really that was an excellent talk, an eye-opener for all of us. Thank you for your time and a very good morning to you. I do have some questions about iMate, but before that, can I just step back a little and have your opinion on when we are using prostaglandin analog and beta blocker fixed drug combinations, what is your preferred timing for dosage? Is it the night time or do you do it in the morning?
Well, prostaglandin analogs, I typically use at night, but it doesn't matter at what time of the day you give them. 28 years ago, I sat in a room in Sweden with Johan Schanskans, who was the inventor of latanoprost. And I was working with Johan and Pharmacia, which was the company that developed it. And we were reviewing data and discussing, when should we give it? Does it make a difference? And we reviewed data that was done in non-human primates. We reviewed data from some of the very early clinical studies. And ultimately we said, well, let's give it at night. And the only reason we decided to give it at night was because there was some hyperemia associated with the administration, particularly for a couple hours after. Not everybody had it. And we thought if it was given at night, patient wouldn't notice the hyperemia. But they're equally effective when given at any time of the day. Beta blockers, perhaps are a little different. Beta blockers being effective during the day, but not during the night, they seem to work a little better when given first thing in the morning. They are also effective when given during the night, not because they lower pressure during the night, they don't, but because they have long-lasting effects. And so, when a beta blocker is used, we recommend that it be used once daily in the morning upon awakening. And of course, we always remind our patients about punctal occlusion, blocking the tear duct to avoid systemic effects. In this case, avoid reducing intraocular pressure.
Right. Thanks very much. And where the iMate is concerned, the version that is available now, as I understand it, is it being done as part of deep sclerectomy, a glaucoma surgery, or is it being done as a standalone procedure?
Well, to date, it's been done in conjunction with glaucoma surgery.
And any chance of extrusion, dislocation, its appearance elsewhere where you did not place it?
So, of course, everybody in this room knows that if you operate, you should prepare for the unexpected. To date, and again, limited number of patients who've received, these the iMate sensors, Sirius Sulcus, and also Suprachoroidal Space. There's been no such complication. No such complication.
Good. Thank you.
Unmute, Dr. Tutul. Unmute.
Can I ask one question, Professor Weinreb? That you were talking about the IOP, the sensors. I have only one question. That what would be the impact in real world scenario? In a sense that it's going to produce lots of noise. So, the real impact in the clinical management.
Yeah, well, that's a great question. So, there is noise. I showed that long list of things that can affect intraocular pressure, throughout the day. And again, what I see is, collecting lots of information will allow us, and I'm speaking as an engineer now, to filter the noise from the signal. But speaking now as a bioinformatics person, which I'm becoming very rapidly, we'll use deep learning strategies to learn, what really is relevant, which of the pressures are relevant in any particular patient. Again, the idea is the more information you collect, the better you'll be able to distinguish the signal from the noise. It's something that we already know. It's just, it hasn't been really widely applied in ophthalmology because we get these single measurements of intraocular pressure. And when you think about it, it's really ridiculous that's how we manage glaucoma. Ridiculous. Sometimes patients are told to have surgery because their pressure is up on a single visit. How ridiculous.
Yes, please.
To tell you what.
Professor Wayne.
Yeah, Mr. Wayne, oh, sorry.
May I?
Go ahead.
I just had a question. That was a very interesting talk, and thank you. But you were talking about the use of the iMate to regulate outflow through drainage devices. Would it be possible to have some kind of a feedback loop for sustained release drugs when you use the...
Yeah, that's exactly the point I was trying to make, is like a servo mechanism where you are getting feedback. You're measuring pressure, you might be releasing a drug, or you might be opening up a valve to lower the intraocular pressure. That's my concept of where management will be going. We'll have drugs, we'll have sustained release. Drugs are not going to go away, but the surgeries continue to improve. So, completely agree. I'm sorry.
No, so I do have a question. May I ask the President, sir?
Please.
Yes,
Go ahead.
My question is something similar to what Rajul asked, that see, there are a lot of variations which are physiological in the intraocular pressure, while the seasonal variation or changing your body position and the way you sleep and all those things. So these variations do not result in glaucoma in individual patients. In most of the people, 98% people don't have glaucoma. So only 2% people have glaucoma. So these variations are going to be there in the patients of glaucoma as well. So are we not going to become hyperactive about these changes if we have this kind of a continuous device implanted everywhere? Of course, I feel that in due course of time, this kind of things will be feasible in a large number of patients. Why? Because technology always moves much faster than what we can think. And the kind of telephones that we have in our hands now, had it been 20 years ago, the same information would require a computer of the size of a room. So this is going to happen, this is possible. But what about these physiological variations which may not have any impact on the health of the optic nerve? They will keep on disturbing our peace of mind and resulting in problems for us.
Well, I hope they don't disturb peace of mind, because remember, with glaucoma, the ultimate goal is not to treat intraocular pressure. The goal is to preserve vision and the vision-related quality of life. And glaucoma is only, one of the many risk factors that we have. So I think, again, by collecting this information will allow us to better treat glaucoma, and detecting peaks in pressure doesn't mean that we're going to treat peaks in pressure unless we can associate those peaks in pressure with worsening of the disease. I'm a data-driven person, and the more data that we collect, whether it's on intraocular pressure or whether it's on the structure of the optic nerve, or whether it's on the function of the optic nerve, whether it's with visual fields or electrophysiologically, the better we'll be able to manage the disease. We need data. we need data. And I see Tutul Chakravarti there, and Tutul, of course, worked with us on she had a Fulbright fellowship. And Tutul did some great work with visual fields, some of which is just beginning to get published now, and taught me a lot about patients with advanced disease, particularly, with the high-resolution 10-2 program. So, hi, Tutul.
Hi, Professor Vainrab. I have a query about it. That till we have any device to monitor 24 hours data of patients' IOP, especially those who are having changes like normal tension glaucoma, pseudoexfoliation, and chronic angle closure glaucoma. So, do you suggest all of them should be monitored through sleep? This lab for the nighttime IOP, and it should be mandatory for all of them.
Well, you're always weighing the risks and the benefits. So we learned very early with our sleep laboratory about what is called normal tension glaucoma. And I used to have many patients sent to me from all over the world with the diagnosis of normal tension glaucoma. What do we do? And the first thing we did was we put them in our sleep laboratory. And the first thing that we found out is that almost all of them had pressure spikes at nighttime. So, I began to think that there really is no entity called normal tension glaucoma. What does that mean? Why would you call somebody with a pressure less than 21 normal tension glaucoma and somebody with a pressure of 22 primary open angle glaucoma? Why, or if your cutoff is 16, why would you call somebody with a 15 one disease and somebody with a 17 the other disease? So I developed the concept of glaucoma being a continuum. And surely, instead of looking at single intraocular pressures, I'm much more interested today in, again, speaking as a mathematician, which is something that I've studied at university at MIT. I think about not single measurements of intraocular pressure, but I think about the integral under the curve. I think about the area under the curve of pressure over time. And, we have certain patients in whom the area under the curve is less than others. And in those patients, we're now finding that they have a genetic susceptibility to damage. So there are certain genes now that seem to predispose the retinal ganglion cell to damage at lower pressures. And other patients can have very, very high intraocular pressure and never develop glaucoma. The point that I heard Dr. Singh talking about, and those patients seem to have genes that protect their retinal ganglion cells. So again, we have to put all of this together, to most effectively treat our patients.
Yeah, Professor Vainrab, sorry to interrupt you. We have so many confounders, and for many we have a control, and for many we don't have the control. For many we may know, for many we may not know. So that you have already discussed. But my simple question is that, during the sleep also we have a different cycle. So have you studied the rapid eye movement and the non-rapid eye movement cycle? That is there any difference between the IOP during sleep?
Yeah. We haven't done it electrophysiologically. We collected at one time 72,000 hours of glaucoma patients sleeping. 72,000 hours of glaucoma patients sleeping. It was all on video. And I looked for medical students who might be interested in getting into a very competitive ophthalmology residency. We needed somebody to look at it. And I never have found anybody. And perhaps I think it's time where we can probably look at those videos again, digitize them, and begin looking at things like rapid eye movements that you typically get during certain stages of sleep, we could look at position of sleep and begin to correlate that. 72,000 hours was a bit too much even for the most ambitious medical student, resident, or fellow.
I have a question, if I may, please.
Yes, please.
Yeah, excellent talk, Professor Feinrup, so thank you for that. My question was related to what you said, that IOP, sleep. So the common drugs that are used in India are dorzolamide and brinzolamide. And I think after prostaglandins, these two are the ones that work next best at night. So between the two of these, what's your experience between dorzolamide?
Thank you. Yeah, thank you for that excellent question. So I tend to group the drugs that we use for pressure lowering into two categories. Those that are effective during the day only, during the daytime, and those that are effective during the daytime and during the nighttime. And as you point out, the ones that I tend to prioritize in my clinical practice are the ones that are effective during the daytime and the nighttime. And the prostaglandin analogs are the most effective, and the carbonic anhydrase inhibitors, as you pointed out, are also effective during the daytime and during the nighttime. And then we've looked at the adrenergic agonists and the beta blockers. They're both very effective during the day, but not effective at nighttime. And the studies are not really, I would say, complete with rho kinase inhibitors and some of the other drugs that we use. We've also looked at laser trabeculoplasty. Laser trabeculoplasty is effective during the day and during the night. We've looked at trabeculectomy, effective during the day and during the night. So I group them, with the prostaglandin analogs and also the carbonic anhydrase inhibitors. I don't, interestingly, I don't do deep sclerectomy surgery, so I don't have any experience with that. In the U.S., we tend to do, have done trabeculectomy, which is the most effective of pressure-lowering treatments. And now I'm thinking that probably more than half of my surgeries are with some type of minimally invasive glaucoma surgery. I would expect that with some of the minimally invasive glaucoma surgeries, for example, the Zen glaucoma implant, that it would be effective during the day and during the night. We have not done, that study. And whether it would be the same with others, I don't know. I don't think so. I think some of the bypass procedures probably won't be effective at nighttime. But I'm just speculating.
So while we are talking about the daytime and nighttime, effect of the drugs, you did mention that most of the glaucoma damage perhaps happens during nighttime. So that means the efficacy of these drugs at nighttime is very important. IOP lowering efficacy is very important. So, but it looks like that most drugs, even if they are effective at nighttime, they are much less effective at nighttime as compared to the daytime. So why is that? I mean, what is it that during sleep which makes these drugs less effective?
So, we don't know. I would say prostaglandin analogs are less effective at nighttime. I wouldn't say it's a huge difference. It's maybe 1 or 2 millimeters mercury difference in efficacy. Carbonic anhydrase inhibitors are very similar during the day and during the night. And, there's something happening, a little differently at night, and we don't really know. Like, we don't really know, why is the pressure at night higher? So part of it is positional. When you go from a sitting or standing position to a supine position, you have increased episcleral pressure, episcleral venous pressure. And so you get an increase in intraocular pressure. But we've done studies, and we've published the results, where we have patients supine for 24 hours. And even when they're supine for 24 hours, their highest pressure is at nighttime. So there's something else going on, and I don't know what that is. I welcome anybody who has any good ideas what might be happening.
I think it's an autonomous nervous system.
Yeah, we think it's autonomic. Absolutely, I couldn't agree with you more. But again, I don't understand
it. I think it becomes a little dormant during sleep. It's not that active. Because of that, probably the epistolar venous pressure goes up, and the pressure goes up during sleep. So that is the only possible mechanism which we can think of.
When this device is ready for commercial use, what do you think, Dr. Venreb, would be the price to the patient? We're always worried about that in a developing country like ours.
Right. So first of all, it's something that, of course, I'm interested in, but I don't have any direct involvement in that. Secondly, the prices will always have to come down, not only for developing countries, but also for developed countries, because the healthcare economics, the budgets that we have are not elastic. Healthcare is very expensive. And so wherever you are, it's important to reduce the price of these devices. And then thirdly, I suspect that there will be other devices as well, because there are several other devices that are under development. They're not quite as far along. The iMate is the only one that's been placed in humans. But, just as in any field, as we develop new technology, the ability to obtain information and the cost of obtaining that information will shrink. We heard earlier about, the computers that were as big as the room. Imagine, today on your iPhone, or many of you probably have a smartwatch. I mean, the technology that you have in these little devices is much more powerful than anything that existed, years ago. I used to, when I was a university student at Massachusetts Institute of Technology and then at Harvard, I remember I would get about 5 seconds to use a mainframe computer that was as large as a house to do things like sort lists alphabetically. And today, of course, the amount that we could do with our smartphone is mind-boggling. And I suspect in 5 years or 10 years from now, we cannot even imagine what we'll be able to do, the computing power that we'll have at our disposal.
One more question from our audience. What, after IOP, in your opinion, is the next risk factor for glaucoma?
So I would say perfusion pressure, maybe even more important than blood pressure, and blood flow. So, how are we going to learn about it? Well, we're very interested in OCT angiography. OCT angiography does not measure blood flow. It teaches us it's a non-invasive method for measuring, vessel density. We're also have just begun study of retinal oxygenation. We're using a new technology to do point-by-point oxygenation maps and hoping to link all that together. I would speculate that there's a possibility that sometime in the future, either in the near future or the distant future, somebody at one time, some smart person at the India Institute of Technology or one of you will say, can you believe that once upon a time they treated glaucoma by lowering eye pressure? And it will be, they'll think it's ridiculous because we'll learn that all the confounding factors and all the other things, there are much better ways to treat glaucoma. But right now, again, I think the most important factor is going to be blood pressure, perfusion pressure, and of course, this is all done in a big environment of the genetic susceptibility of individuals, because we already have more than 100 genes that contribute to primary open-angle glaucoma, and each one of them probably has, provides variations on susceptibility of the retinal ganglion cells to damage. Very exciting time to be in glaucoma. And I think so over the next 10 years, there are going to be tremendous changes as we unravel the genetics, learn more about intraocular pressure, develop better functional tests and better structural tests for glaucoma.
Absolutely.
What should be the cutoff value for the perfusion pressure, sir? 40, 50, 30?
I'm sorry, I didn't follow that question.
What should be the cutoff value for the perfusion pressure? 50, 40, 30, what? It should not go below that perfusion pressure.
Cutoff value. So are you talking about diastolic blood pressure or?
The diastolic perfusion pressure.
We don't know, but if I have a patient, if I have patients, and these very often are sent to me for recommendations or treatment, and we get 24-hour blood pressure measurements, and if we have somebody who's progressively worsening, despite what appears to be low intraocular pressure, and their diastolic blood pressure is under 60 millimeters of mercury, at night, I'm very suspicious that there's a perfusion problem. And I'll look at, what are they doing for their blood? Many of these patients are being treated for hypertension because during the day they're hypertensive. Their blood pressure is hypertensive. And we adjust their blood pressure medications. And somebody whose diastolic blood pressure is lower than 50 millimeters of mercury, I think there's a very high likelihood that that's contributing to glaucoma worsening. Remember, we have about 10 to 15% of individuals have been termed dippers. Have you ever heard that term, dippers, where the blood pressure gets very, very low? And there's a very high prevalence in the glaucoma community of dippers. The question is, what do you do? You can identify it, but what do you do about it? That's the problem right now. And I think that's where, we'll have a whole new generation of therapeutics.
Dr. Mayuri, you want to ask a question? Yeah.
Shanta wanted to ask question. Shanta, would you like to do that? No. Okay, sir, I have a question. Where will you place the indication of in the present day status? Would you like to put this device in all the patients, or you have a selection that in this particular patient I should?
To the patients undergoing glaucoma surgery, and most patients are not undergoing glaucoma surgery. But as the device, this device and other devices, as they shrink in size, the market for them will increase. The number of individuals that you'll be able to place them in will be much, much larger. And then again, as I mentioned earlier, imagine being able to do this in a clinic. Imagine being able to, just like you might place a needle in the anterior chamber today, being able to inject something, then the number of individuals that, will receive these devices will dramatically increase. So if the cost is low, if the devices are tiny, if the application is safe and easy, I see no reason why every patient with glaucoma shouldn't have it. I would certainly want one if I had glaucoma. And you might even argue that patients with ocular hypertension and other risk factors, might be suitable candidates as well. But it's not there yet. This is still some time away.
Thank you, sir.
So if we don't have any other questions, we are actually past time.
Yeah, you kept me very busy. You kept me very busy this morning, Dr. Paul, Dr. Panda, but these are all great questions. And again, I congratulate you. This is a fantastic society. It's the first time that I've actually spoken. And I'm so pleased to learn more, and a big shout out to all, my fantastic colleagues, in India, my glaucoma colleagues. Many of you I've met at the Hamilton Glaucoma Center, and I've met some of you at meetings. I've met some at the WGA. And Dr. Parekh, I don't think we really formally met. And it's such a pleasure to meet you because I know of your contributions to the World Glaucoma Association. So with that, I wish you all a good evening. And now that I see everybody's faces, I'm hoping that we can all go live. And when we bump into each other at maybe a World Glaucoma Congress or some other meeting, we'll be able to say hello to each other. So,
Professor, we have met quite a few times, but in all the WGC, so I've met you quite a few times in all the WGC.
Right, but never really had the opportunity to.
I do not remember.
So we'd like to invite you to the annual Glaucoma Society conference, and we hope to hear you live in our own country at our own GSI conference, maybe once the COVID situation is over. I keep my invitation open for the next GSIs which follow, so that you can hear you live, which would be much, much more exciting.
You know, it's interesting. Over the years, I've had a number of invitations, wonderful, you know, just prestigious invitations to speak at anniversaries of institutes and things like that. And I've never been able to go. I've always had conflicts of you know, other things that I had committed to earlier. And so incredibly, India is probably, you know, the only one of the really major places in the world that I'd love to go to. So thank you very much. Hopefully.
Wonderful. The GSI next year is in Delhi, the capital. So maybe a year hence, and if COVID is all right, we extend an invitation to you for the Delhi conference, maybe sometime next year in 2022, November.
Well, thank you. I have a feeling it'll be a little while longer for all of us. And again, my prayers for all of you in India. You know, I've been, you know, hearing and learning about, you know, COVID in India, and hoping everybody can get vaccinated and get safe and get the Delta variant under control, and that all of you and your families are safe. We just opened up everything in San Diego. Our restaurants are open, our beaches are open, the movie theaters are open, and we're beginning now to have all of our conferences again. When Tutul was with us, she was lucky to escape. I remember we didn't know how she was going to return to India, but it'll get better. Everything will get better in India. So okay. Good night.
Thank you very much.
Thank you very much.
We had a wonderful discussion and wonderful talks, and I'm sure everyone's benefited. Thank you all very much for joining us. Web portal as well. Thank you all.
I'd like to thank the Milmed division of Sun Pharma for offering to take care of this webinar. Thank you very much, Mr. Mahajan and Mr. Joydeep Banerjee. Thank you very much. And thank you, all of you, for being here this evening and making it such a successful webinar. Thank you very much. Thank you.
Thank you. Good night.
Good night, everyone.
Good night.
Good night.